So, welcome to Kanski lecture series, and today we are going to start the eyelid part 2. And in this part, we are going to discuss about the non-neoplastic lesions, that is number one, lesion, and which is also known as meibomian cyst. As you know, that lesion is basically the inflammation of the meibomian gland. So, let's see how it presents. Pathogenesis. A lesion is a sterile chronic granulomatous inflammatory lesion, lipogranuloma of the meibomian, or sometimes cysts glands caused by the retained sebaceous secretion. So basically, it is an inflammatory lesion, and it is basically associated with the meibomian gland, but sometimes with the glands of cysts, and it is caused by the retained sebaceous secretion. Histopathology show a lipogranulomatous chronic inflammatory picture with extracellular fat deposit surrounded by the lipid-laden epithelioid cells, multinucleated giant cells, and lymphocytes. So, what do we have in the biopsy of a lesion? It is going to be basically a lipid-laden cells. There will be the fat deposits. It will be the extracellular. So these are the cells, and in between the cells there will be the fat deposition, and surrounding around these will be epithelioid cells, multinucleated giant cells, and lymphocytes. Blepharitis is commonly present. Rosacea can be associated with multiple and recurrent lesions. Bortezomib, a proteasome inhibitor used in the treatment of the multiple myeloma, predisposes to the formation of the chlamydia within 3 months of initiation of treatment. A recurrent chlamydia should be biopsied to exclude a masquerading malignancy. So there are certain kinds of risk factors that are associated with the formation of blepharitis. One is with occlusion, one is blepharitis, and other one is we have a condition called rosacea, and third is if the patient has is on the multiple myeloma treatment and he is using the bortezomib, and it's also occur. And one, if there is a patient presents us with repeated lesion, and his age is greater than 60 years, then one should always suspect some masquerading lesions such as sebaceous gland carcinoma as well. So and that's it. So let's see about the biopsy. So this is a lesion. Figure 2.2a is showing the histopathology, showing the lipogranuloma, the large pale cell with epithelioid cells and well demarcated empty spaces contained fat dissolved out during processing. So you can see these are the empty spaces, and it is basically due to the fat that has been dissolved during the processes, and there are the large pale epithelioid cells. B is showing the uninflamed lesion. C is showing the marginal lesion with superimposed bacterial infection. D is showing the conjunctival lesion, and E is showing the conjunctival view of lesion clamp in place after curettage. So how does it present? So diagnosis of the lesion is quite simple. Symptoms include subacute or chronic gradually enlarging painless rounded nodule, acute sterile inflammation or bacterial infection with localized cellulitis. A secondarily infected meibomian gland is referred to as internal nodulum. So we have to discuss about these terms. So basically, the lesion presents us as a chronic uh, stage. It will be having a nodule that will be painless and gradually enlarging. But if it is acute, it may present with bacterial infection, and there can be a localized cellulitis with it. And there are two types of nodulum: external nodulum and internal nodulum. The external nodulum is also known as sty, which is associated with the lash follicle, whereas the internal nodulum is a secondarily infected meibomian gland. So when the lesion is infected, it is called the internal nodule. Signs are a nodule within a tarsal plate, sometimes with associated inflammation. You know that meibomian glands are present within a tarsal plate, so this nodule will be within the tarsal plate. So whenever you find a person with a lesion, you will feel that a lesion is deeper than its usually look. Bulging in secreted secretion may be visible at the orifice of the involved gland. There may be associated conjunctival granuloma. So, what is a conjunctival granuloma? So, what happens if there is a patient presented with lesion? When you evert the eyelid, you will see the granuloma formation in the part of the conjunctiva, which also suggests that this is a lesion. A lesion at the interior lid margin may be connected to a typical lesion deeper in the lid or due to isolated involvement of a gland of Z's. Treatment. Treatment is with oral antibiotics are required for the significant bacterial infection but not for sterile inflammation. So you have to know that is this lesion is infected or it is sterile. If it is infected, you can give oral antibiotics, but if it's not, then there is no need to give the oral antibiotics. Conservative treatment, at least a one third patient resolves spontaneously, so observation may be appropriate, especially if the lesion is showing signs of improvement. Hot compresses application several times daily may aid resolution, particularly in early lesion. Expression Compression between the two cotton tipped applicators is sometimes effective in expressing the content of a fresh lesion near the lid margin. So what you can do is basically you can do conservative management. You can observe the lesion if it is a newly formed lesion. You can also do hot compresses, and you can also express the lesion with the cotton tip applicator on it. So there are two types of procedure that can be done in the lesion. Number one is steroid injection and surgery. Both have advantages and disadvantages. Basically, we use steroid injection when the lesion is near the lid margin and it is very small lesion. So you can do the steroid injection, and we give the triamcinolone injection. But it has certain kinds of disadvantages, like it can cause fat atrophy, and it also can cause the depigmentation of the skin. Steroid injection into and around the lesion has been reported to give the similar resolution rate to incision and curettage. It may be preferred for marginal lesion or lesion close to the structure, such as lacrimal punctum, because of the risk of surgical damage. Uh, Reported regime. Reported regimes include 0.2 to 2 ml of triamcinolone acetonide aqueous solution suspension diluted with the lignocaine to a concentration of 5 mg per ml, and zero point 0.1 to 0.2 ml of 40 milligram per ml injected mm, with a 25, 27 or 30 gauge needle. The success rate following one injection is about 80%. A second injection may be given 1 to 2 weeks later. So how do you give basically, let me simplify this for you. Then how do you give the triamcinolone? Basically, we give only the we have injection of triamcinolone as a 40 mg per ml. So what happen is, because you just take a 0.1 to 2 ml of this injection and then dilute it with lidocaine, lidocaine, and you give the patient that injection. And you can give the injection, and basically the injection success rate is 80%, but you can repeat it after 1 week as well. Local skin depigmentation and fat atrophy are uncommon complication which are less likely to occur by utilizing a conjunctival approach. Retinal vascular occlusion has been described as a rare complication, but it is a complication of a steroid injection. The retinal vascular occlusion, especially the retinal artery occlusion, central retinal artery occlusion. Surgery. Following local anesthesia infiltration, the eyelid is aorted with a specialized clamp. The cyst is incised vertically through the tarsal plate and its content curated. Limited excision of the solid inflammatory material sent for histopathology with fine scissors may be helpful in some cases, especially if there is no focus of secretion. A suture should not be used. Topical antibiotic is used 3 times daily for 5 days following curettage. So, how do we do the procedure? So, we have basically a Clasion clamp and a curettage that we use in case of Clasion removal. So, Clasion clamp is basically used to evert the eyelid and secure the eyelid. So, when the eyelid is everted, you will have the conjunctival part of the Clasion, and you can identify it with the conjunctival granuloma of the Clasion. And then you give the vertical incision into the Clasion, and when you give the vertical incision, you take the curettage and then remove all the secretions and material in it, and you can also send the tissue for the biopsy. You don't need to give it, the incision is very small, and you do not need to have any suture after that, and you can just give the topical antibiotics for 5 days after the removal. Marginal lesions can be managed by steroid injection, by curettage of an associated deeper Clasion, by shave curettage, or by incision of and curettage by a horizontal incision on the conjunctival surface, and vertically through the grave line. So this is somehow different. Marginal lesions are the that Clasion which are usually very close to the eyelid margin. So like let's see, like this. So what you can do is you can just curettage, you can do the shave curettage, like you can biopsy it, shave biopsy, and then you can also incise and then curettage. Curettage mean basically you scoop the lesion and you remove it all together. So if it is a if you want to give the incision on the conjunctival surface, then you give it horizontally like this, and if you want to give on the lid margin, then you give it vertically. It is slightly different than that of the regular Clasion. Prophylaxis is treatment of blepharitis, for example, daily lid hygiene regime. Systemic tetracycline may be required as prophylaxis in patients with recurrent chlamydia, particularly if associated with acne rosacea. Other eyelid cysts. So these are also very important cysts. Cyst of Zeiss is basically the cyst associated with the gland of Zeiss. It is a small non-translucent cyst on the interior lid margin arising from the obstructed sebaceous gland associated with the lash follicle. So it is basically the sebaceous gland that is associated with lash follicle, and because these are obstructed, it gives the experience of non-translucent cyst, whereas cyst of mole is basically transparent cyst, just a difference. So you can see that this is a cyst of Zeiss. It is associated with lash follicle, it is slightly interior, and you can see it is a non-translucent cyst. And B is showing the cyst of mole, which is slightly translucent. Cyst of mole is also known as apocrine hydrocystoma. It is a small retention cyst of the lid margin apocrine gland. It appears as a large, round, non-tender, translucent fluid-filled lesion on the interior lid margin. Then there is a sebaceous cyst. It is caused by the blocked pilosebaceous follicle and contains sebaceous secretion. The gland orifice is often visible. It is often only rarely found in the eyelids, though it may occasionally occur in the at the inner canthus. Comedones. Comedones are the plugs of keratin and sebum within a dilated orifice of the hair follicle that often occur in patients with acne vulgaris. So, what is comedones? So, in a patient of acne vulgaris, there will be the plugs of keratin and sebum that are in the dilated hair follicles. They may be either open blackheads containing a dark A darkened plugged or oxidized material are closed, which is known as whitehead. So you can see figure 2.3 is showing the sebaceous cyst, and B is showing the uh, D is showing the comedones, blackheads. Melia is caused by the occlusion of the spinosebaceous unit, resulting in the retention of the keratin. So it is a occlusion of the pilosebaceous unit. These are tiny white round superficial papules that tend to occur in crops. So these are, look, you can see it's a whitish, and they tend to occur in crops like a large amount. Epidermal inclusion cyst is usually caused by the implantation of epidermis into the dermis following trauma or surgery. It is a slow growing, round, firm, superficial or subcutaneous lesion containing keratin. So epidermal inclusion cyst is basically the dermis layer contain the epidermis layer, and it is occur during following the surgery or trauma. Epidermoid cyst is uncommon and usually developmental, occurring along the embryonic line of closure. It is similar in appearance to the epidermal inclusion cyst. So basically, epidermal inclusion cyst and epidermoid cyst are similar. Just the difference is that epidermoid cyst is developmental, whereas epidermal inclusion cyst is after the surgery or trauma. So we can see the figure 2.3. So these are melia, and these are epidermal inclusion cyst, and G is showing us a dermoid cyst, and E is showing acrine hydrocystoma. So what is apocrine hydrocystoma? It is basically the gland of mole. Dermoid cyst is usually subcutaneous and deeper, and is typically attached to the periosteum at the lateral canthal of the probe. So it has a bony involvement. It is caused by the skin sequestered during the embryonic development. Acrine hydrocystoma is less common but similar in appearance to the cystoma mole, except that it is usually located along the medial or the lateral aspect of the lid and is close to but does not involve the lid margin itself. Xanthilesma. Xanthilesma is basically the fat deposition, and you can see the yellowish lesion on the skin of the eyelids. Xanthilesma, plural xanthilesmata, is common, frequently bilateral condition, typically affecting the middle-aged and elderly individual. It is a subtype of xanthoma. Hyperlipidemia is found to be about one-third of the patient, in whom corneal arcus may also be present, in contrast to the clasion. In contrast to the clasion, fat in the xanthilesmata is mainly intracellular, with lipid-laden histiocyte foam cells in the dermis. So basically, it in clasion there is the extracellular fat, but in xanthilesma there is an intracellular fat, and there will be the foamy lipid-laden histiocytes or foam cells in the dermis. So you can see figure 2.4. A is showing histopathology, showing foamy cell histiocytes within a dermis. And you can also see the B is showing the large isolated lesion, D is showing the small isolated lesions. Xanthilesmata are the yellowish subcutaneous plaques, usually in the medial aspect of the eyelid, commonly bilateral, and are multiple. So these are the plaque-like formation, and it is yellowish in color. Treatment is principally for cosmosis. Recurrence up to into 50% and is common in patient with hypercholesterolemia. So these are basically present in a patient who are already affected with the hyperlipidemia. And one thing is that these patients also have a corneal arcus in them. So how will you treat? You can treat it with simple excision. Is commonly performed where adequate skin is present. So what you do is, for example, if this is a eyelid skin and there is a xanthilesma present, you just excise it, remove it, and then close the remaining skin. Micro dissection is for the larger lesion can be raised in flaps, the fatty deposit dissected from the underlying skin under the surgical microscope using a micro scissor and the skin replaced. So micro dissection is basically if there is a very large xanthelasma, you just raise that flap and then underlying you remove the underlying fat from it, and then you place the flap back. This is called micro dissection. Other methods, good result can be obtained using a chemical peeling with bi or trichloroacetic acid. Laser ablation and cryotherapy have advantages but are more prone to scarring, including the pigmentary changes. So these are usually the procedures that are being done by the dermatologist. So that's it for the eyelid part 2. See you in the next lecture.